Airborne bacterial diseases. Respiratory system diseases can be grouped into two general categories. One is the diseases of the upper respiratory tract, and two, diseases of the lower respiratory tract. The respiratory system is the most common portal of entry for infectious agents. The respiratory system is composed of a conducting portion that brings oxygen to the lungs and a respiratory portion that exchanges oxygen and carbon dioxide gases with the bloodstream. Because air typically contains microbes and viruses carried on dust and droplet nuclei, it should not be surprising that the respiratory system is the most common portal of entry for these infectious agents. The respiratory system is divided into the upper respiratory tract and the lower respiratory tract. The upper respiratory tract is composed of the nose, sinus cavities, and the pharynx, or more commonly known as the throat. The lower respiratory tract is composed of the larynx, trachea, bronchi, and lungs. The lungs contain the alveoli where gas exchange occurs. The average adult inhales and exhales approximately 10,000 liters of air per day. The inspired or inhaled air contains microbes that may cause infection. The respiratory system has evolved effective mechanisms to defend against respiratory illnesses. During breathing, the upper respiratory tract and bronchi play a critical role in filtering out foreign material, including bacteria, viruses, and dust particles that might carry pathogenic microorganisms. One of these defense mechanisms is called mucociliary clearance. This process involves the entrapment of microbes and particulate matter larger than 2 micrometers in a layer of mucus. These particles are then moved by ciliated epithelial cells toward the pharynx, where it is either swallowed or coughed up and expelled from the body. Mucociliary clearance is supplemented by the presence and activity of several antimicrobial substances. These substances include lysozyme, lactoferrin, anionic antimicrobial peptide, IgA and IgG antibodies, defensins, and vitamin D. In the nose, large particles present in inhaled air are removed by hairs in the nostrils, while smaller particles and suspended bacteria become trapped in the mucus covering the nasal mucosa. In the posterior 2/3 of the nasal mucosa, the mucociliary clearance also propels the mucus-entrapped particles into the pharynx. However, in the anterior region of the nasal mucosa, the disposal of these entrapped microbes is largely dependent on microbicidal substances present in nasal fluid. The lower respiratory tract contains epithelial cells that line the alveoli and the respiratory bronchioles. These epithelial cells are not ciliated. However, the region is covered by alveolar fluid, which contains a number of antimicrobial components, including lysozyme, immunoglobulins, and neutrophils. Immunoglobulin is an IgG which facilitates the phagocytosis of any microbes lining this part of the respiratory tract. Neutrophils are recruited when larger numbers of microbes enter the alveoli. The alveolar macrophages recruit these neutrophils from the pulmonary capillaries in order to clear the invaders. The upper respiratory tract has constant exposure to the outer environment. This means that many different organisms can form part of the normal microbiota, sometimes called the normal flora of the body. The normal microbiota is the microbial community found on and in the body. Normal microbiota have the upper hand for occupying space and sequestering nutrients. This helps prevent the ability of disease-causing organisms or pathogens to compete for space and nutrients, and thus to colonize and cause infections in the respiratory system. Let's look at some of the normal flora or microbiota in the respiratory tract. The nose is colonized by Corynebacteria and Propionibacteria. The nasopharynx, which is the upper portion of the pharynx or throat, is colonized by Streptococci, Neisseria, and Haemophilus. The oropharynx, which is the middle portion of the pharynx or throat, is colonized by Haemophilus, Neisseria, and Streptococci. In the lower respiratory tract, there is little, if any, microbiota. Small numbers of bacterial cells may be found in the larynx and trachea, but they are usually transient and are usually eliminated by the cellular and chemical immune defenses of the lower respiratory tract. Bacterial diseases of the upper respiratory tract can be severe. This is because the respiratory tract is a portal of entry to the blood, and from there, bacterial pathogens can spread to other sensitive organs. A sore throat, known medically as pharyngitis, is not a disease in itself. Pharyngitis is a generalized medical term used for the inflammation of the throat. Inflammation of the throat can be caused by several different viruses and bacteria. Streptococcus pyogenes causes strep throat and scarlet fever. S. pyogenes is also carried in the throat and is the most common cause of tonsillitis, which is inflammation of the tonsils. Strep throat is highly contagious and reaches the upper respiratory tract through respiratory droplets that were expelled by an infected person during coughing or sneezing. The symptoms of strep throat include a severe and sudden sore throat, fever, headache, swollen lymph nodes and tonsils, and a red appearance to the throat. Strep throat can be treated using oral antibiotics such as penicillin, or in extreme or recurrent cases, a tonsillectomy can be performed. S. pyogenes also causes scarlet fever. Scarlet fever affects about 10% of children with streptococcal pharyngitis. These strains of S. pyogenes contain erythrogenic exotoxins that cause a pinkish-red rash on the neck, chest, and soft skin areas of the arms. The rash, which usually occurs in children under 15 years of age, results from blood leaking through the walls of the capillaries damaged by these toxins. Other symptoms include a sore throat, fever, and a strawberry-like inflamed tongue. Scarlet fever can be treated using antibiotics such as penicillin or clarithromycin. These antibiotics can shorten the duration of symptoms and can prevent serious complications. Rheumatic fever is most common in young school-aged children. It is not an infection, but rather an inflammation in response to a throat infection. Rheumatic fever primarily affects the joints and the heart, and is characterized by fever and joint pain. The most significant long-range effect of rheumatic fever is permanent scarring and distortion of the heart valves in a condition called rheumatic heart disease. Rheumatic heart disease arises from a response of the body's antibodies to streptococcal M proteins. These antibodies cross-react with similar proteins located on the heart muscle. Another complication arising from streptococcal pharyngitis or strep throat is acute glomerulonephritis. Acute glomerulonephritis is a rare inflammatory response to specific types of M proteins. The antigen-antibody complex is formed, then accumulate in the glomerulus of the kidney. Acute glomerulonephritis is most common in young patients. When occurring in older adults, it may lead to progressive, irreversible kidney damage. Diphtheria is a life-threatening illness of the upper respiratory tract caused by Corynebacterium diphtheriae. Corynebacterium diphtheriae secretes a toxin that inhibits protein synthesis in epithelial cells. Diphtheria is acquired by inhaling respiratory droplets from an infected person. Following a short incubation period of about 2 to 4 days, the initial symptoms present themselves as a sore throat and a low-grade fever. In epithelial cells, the bacterial cells secrete a potent exotoxin, which is encoded by a virus that infects the C. diphtheriae bacteria. The exotoxin inhibits the translation process done by ribosomes. This results in an accumulation of dead tissue, mucus, white blood cells, and fibrous material called a pseudomembrane. It's called a pseudomembrane because it does not fit the definition of a true membrane. This pseudomembrane will be located on the tonsils or the pharynx. Mild cases of diphtheria fade after about a week, while more severe cases can persist 2 to 6 weeks. Complications can arise if the thickened pseudomembrane results in respiratory blockage causing suffocation. If the exotoxin spreads to the bloodstream, heart, and peripheral nervous system, destruction can lead to cardiac arrhythmia and coma. Left untreated, diphtheria can result in death in 5 to 10% of cases. Treatment for diphtheria requires antibiotics in the form of penicillin or erythromycin, or antibodies to neutralize the exotoxins. Immunization against diphtheria induces the immune system to produce antibodies that circulate in the bloodstream throughout the person's lifetime. Due to immunization starting in early childhood, the number of cases of diphtheria in the United States is essentially zero. In fact, the last confirmed case was in 2003. However, this disease remains a health problem in many regions of the world, and booster doses are required. The World Health Organization, or the WHO, reported 4,190 cases of diphtheria in 2007, with 80% of those cases occurring in India. The epiglottis is subject to infection, especially in children. Swelling of the epiglottis can be dangerous because it can block the trachea. A life-threatening but rare condition called epiglottitis involves infection of the epiglottis, which is the small flap of cartilage that covers the trachea. If the area around the epiglottis becomes infected with H. influenzae or S. pneumoniae, the inflammation can spread to the epiglottis, which may swell such that it blocks the flow of air through the trachea into the lungs. Symptoms of epiglottitis include severe throat pain, fever, a muffled voice, narrowing of the airways, and a stridor, which is a high-pitched wheezing sound when breathing in or out. This condition can progress rapidly, making breathing even more difficult. In rare cases of epiglottitis, where medical intervention does not occur, a complete airway blocking can result in death. The infection is most common and most dangerous in children because they have smaller airways than adults do. If the individual is breathing freely, intravenous antibiotics are given. Immunization with the HIV vaccine is the most effective way to prevent epiglottitis in children under 5. The nose is the most commonly infected region of the upper respiratory tract. Because of its prominent position in the upper respiratory tract, the nose is the major portal of entry for infectious organisms and viruses. S. aureus is the most common agent of infection. S. aureus can result in boils that may develop into cellulitis, which is an infection under the skin at the tip of the nose. Because this part of the face contains veins leading to the brain, venous spread of bacteria can lead to a life-threatening condition called cavernous sinus thrombosis. Sinusitis is an inflammation of the sinuses. The sinuses are air-filled hollow cavities that surround the nose and nasal passages. The inflammation is most commonly caused by an allergy or infection and represents one of the most common medical conditions. Sinusitis nearly always occurs in connection with inflammation of nasal passages called rhinitis, and some doctors refer to this disorder as rhinosinusitis. Acute sinusitis may be caused by a variety of indigenous microbiota of the upper respiratory tract. The condition often develops from a blockage at the openings to the sinuses resulting from a common cold infection of the upper respiratory tract. Fluid trapped in the sinuses then becomes a nutrient growth medium for potential bacterial pathogens including S. pneumoniae and H. influenzae. In addition, white blood cells and more fluid enter the sinuses to fight the infection. This only increases the pressure and pain experienced by those suffering from sinusitis. Acute sinusitis usually results in pain, tenderness, swelling, a yellow or green nasal discharge, fever, and chills. Treatment of acute sinusitis is aimed at improving sinus drainage and curing the underlying infection. Nasal sprays can be used for a short period of time, and antibiotics such as amoxicillin, trimethoprim, and sulfamethoxazole can be given. If untreated, acute sinusitis may develop into a chronic condition, referred to as chronic sinusitis. Chronic sinusitis is defined as an infection that has been going on for 8 to 12 weeks. Preventing or reducing the risk of developing chronic sinusitis can be accomplished through good hygiene, frequent hand washing, and treating cold symptoms immediately by using decongestants. Ear infections are common illnesses in early childhood. A few ear infections can occur in the outer ear. An outer ear infection is referred to medically as otitis externa. Otitis externa can affect the entire ear canal or just one small area, resulting in a boil or pimple-like formation. Normally, the ceruminous glands in the ear canal produce earwax that has antibacterial activity. However, outer ear infections commonly occur in children, especially after extended swimming in freshwater pools. This can result in excessive moisture in the ear canal, which irritates and breaks down the skin in the canal, allowing bacterial cells to penetrate. Such infections are commonly called swimmer's ear. A bacterial infection is most often caused by different species of Streptococcus, Staphylococcus, and Pseudomonas. The primary symptoms of otitis externa are itching, followed by ear pain. Treatment involves the application of antibiotic ear drops administered to the ear several times a day for about 1 week. Swimmer's ear can be prevented by not swimming in polluted water and using earplugs to keep the canal dry when swimming, showering, or bathing. Short-term infections of the middle ear are called acute otitis media. Such infections are among the most common illnesses of early childhood. 3 out of 4 children contract at least one ear infection by the age of 3. Bacteria typically responsible for middle ear infections include S. pneumoniae and H. influenzae. Middle ear infections usually start with a common cold infection of the upper respiratory tract. Inflammation of the eustachian tube allows this bacteria to infect the sterile environment of the middle ear, where fluid buildup then provides an environment primed for bacterial growth. This is followed by ear pain with a red, bulging eardrum. Children with ear infections may develop a fever, produce fluid that drains from the ears, or experience headaches. They may also have trouble sleeping and might be unusually irritable. Most individuals get better without treatment. In fact, 80% of children with otitis media recover without antibiotics. For chronic bacterial infections, a physician may decide to administer an antibiotic such as amoxicillin. Chronic otitis media is a condition involving long-term infection, inflammation, and damage to the middle ear. Chronic otitis media is a persistent fluid infection in the ears that lasts for months, and the only symptom seems to be hearing impairment. It is now recognized that chronic otitis media is not the result of reinfection, but rather stems from a persistent biofilm that has colonized the middle ear tissues. Treatment involves antibiotic ear drops, oral antibiotics, or a surgery to clear the obstruction. Acute bacterial meningitis is a life-threatening inflammation of the meninges. It is most common among children aged 1 month to 2 years. The meninges are the membranes covering the brain and the spinal cord. Let's look at the pathogenic steps that lead to meningitis. First, the bacterial species capable of causing meningitis, such as in meningitis, S. pneumoniae, and H. influenzae, will colonize the nasopharynx. Then, these bacteria invade the epithelium, causing respiratory distress. From here, the bacteria can pass into the bloodstream. Finally, the bacteria will disseminate to the tissues near the spinal cord, causing inflammation and meningitis. Infection through the meninges, brain, and spinal cord can be very rapid, resulting in death within hours. A particularly dangerous form of meningitis is meningococcal meningitis, caused by the bacterium in meningitis. In meningitis is a pathogen that attaches to the nasal pharyngeal mucosa by pili and forms a capsule, resulting in lesions on the adrenal glands, leading to hormonal imbalances. Some cases can lead to a condition called Waterhouse-Friderichsen syndrome, which results in the release of a bacterial endotoxin into the blood. Death can occur within 10 to 12 hours. Streptococcus pneumoniae is the major cause of bacterial pneumonia. Pneumococcal pneumonia can develop into pneumococcal meningitis, which is lethal in 20 to 30% of cases. Haemophilus influenzae type B once was the most prevalent bacterial species causing meningitis in children between the ages of 2 months and 5 years. In 1986, about 18,000 such cases of Haemophilus meningitis occurred in the United States, killing about 1,000 children. In 1993, a vaccine for children called Tetramune was approved by the FDA, and in 2007, the number of reported cases among children under 5 years of age in the United States was down to only 22. Another type of meningitis, meningococcemia. In meningococcemia, the meninges become inflamed, causing pressure on the spinal cord and brain. Patients normally experience a fever and a stiff neck. Symptoms rapidly evolve into a pounding headache, nausea, and vomiting, usually accompanied by a sensitivity to bright light. A rash also appears on the skin, beginning as bright red patches, which then progresses to bluish-black spots. Left untreated, 50% of cases of meningococcal meningitis result in coma or death within only a few hours. The disease can also produce lasting disabilities such as deafness, blindness, and paralysis. Unfortunately, no single vaccine provides immunity to all causes of meningitis. A meningococcal polysaccharide vaccine called Mnemone has been available since 1978, and a new capsular vaccine called Menactra, which vaccinates against serogroups A, C, Gamma, and W135, is available. The CDC strongly recommends all college freshmen be immunized before taking up residence in a college dorm. Vaccines against pneumococcal and Haemophilus meningitis are also available. In the lower respiratory tract, a number of bacterial diseases can affect the lung tissues. As injury occurs, fluid builds up in the lung cavity, and the space for obtaining oxygen and eliminating carbon dioxide is reduced. This is the basis for possibly fatal pneumonia. Pertussis, or whooping cough, is caused by Bordetella pertussis. Bordetella pertussis secretes toxins that destroy cells of the ciliated epithelium of the lower respiratory tract. Pertussis is spread by respiratory droplets that adhere to and aggregate on the cilia of epithelial cells in the mouth and throat. Bordetella pertussis secretes toxins that destroy cells of ciliated epithelium. Exotoxin produces paralysis in ciliated cells and impairs mucus movement, potentially causing pneumonia. Typical cases of pertussis occur in 2 stages, lasting 4 to 12 weeks. The initial stage, called the catarrhal stage, is marked by general malaise, low-grade fever, and an increasingly severe cough. During the second stage, called the paroxysmal stage, disintegrating cells and mucus accumulate in the airways and cause labored breathing. Patients experience multiple paroxysms, which consist of rapid-fire staccato coughs, all in one exhalation, followed by a forced inhalation over a partially closed glottis. This rapid inhalation results in a characteristic whoop, hence the name whooping cough. 10 to 15 paroxysms may occur daily, and exhaustion usually follows. Erythromycin reduces the duration and severity of the illness. There is a vaccination against pertussis available. However, many people use their immunity 5 to 10 years after receiving the vaccination. Tuberculosis is one of the greatest challenges to global health. The WHO estimates that some 2 billion individuals, which is 1/3 of the world's population, are infected with TB bacillus, and 2 million die of TB every year. Tuberculosis is caused by Mycobacterium tuberculosis. Tuberculosis is primarily an airborne disease, and as such, the bacilli are transmitted from person to person in small aerosolized droplets when a person with active pulmonary disease sneezes, coughs, spits, or even sings. Tuberculosis is caused by a bacteria called Mycobacterium tuberculosis. Tuberculosis is a two-stage illness. The first stage is called the infection stage, which is followed by the second stage called a diseased stage. In the infection stage, a patient is said to have a primary tuberculosis or TB infection. If tested, the person would have a positive tuberculin reaction, but a chest X-ray and sputum test would be negative. In the alveoli, macrophages respond to the infection by ingesting the bacilli bacterium. Unfortunately, the bacteria are not killed in the macrophages, and when more macrophages arrive to help, they also phagocytize the bacteria but are incapable of destroying them. Eventually, lymphocytes and fibroblasts surround the mass in the lung, forming a hard nodule called a tubercle, hence the name tuberculosis. These tubercles may be visible in a chest X-ray. In 90% of primary TB infections, the infection becomes arrested. The tubercles heal and undergo fibrosis and calcification. This dormant form of TB is referred to as latent TB infection and is carried by approximately 2 billion people worldwide. Up to 10% of individuals who have primary or latent TB infection will develop the second stage of the disease, called the disease stage or the clinical stage. Primary TB infections can develop into primary active TB disease, and latent TB infections can be reactivated and also develop into secondary active TB disease. Within 3 months, infected individuals experience chronic cough, chest pain, high fever, and the production of sputum that is rust-colored, which indicates that blood has entered the lungs. These individuals will now have a positive tuberculin reaction as well as a positive chest X-ray and sputum test for tuberculosis. TB has traditionally been treated with such first-line drugs such as isoniazid and rifampin. Ethambutol, pyrazinamide, and streptomycin are also used to help delay the emergence of resistant strains. Multi-drug resistant tuberculosis, or MDR-TB, has occurred and now accounts for 5% of new tuberculosis cases. This has necessitated a switch to a group of second-line drugs, including fluoroquinolones and kanamycin. Even worse strains, called extensive drug-resistant tuberculosis, or XDR-TB, has been reported in some 50 countries. This still rare form of TB is resistant to almost all drugs used to treat tuberculosis, including isoniazid, rifampin, fluoroquinolones, and kanamycin. Very few treatment options remain for those individuals suffering from extensively drug-resistant tuberculosis. A successful outcome depends upon the extent of M. tuberculosis drug resistance, the severity of the disease, and whether the patient's immune system has become weakened. Bronchitis is an inflammation of the bronchi. Bronchitis produces excessive mucus and narrowing of the bronchi. Infectious bronchitis occurs most often during the winter and can be caused by bacterial species following an upper respiratory tract viral infection such as the common cold. Mycoplasma pneumoniae and Chlamydophila pneumoniae often cause bacterial bronchitis in young adults, while S. pneumoniae and H. influenzae are the primary agents among middle-aged and older individuals. Infectious bronchitis produces excessive mucus and narrowing of the bronchi. Infectious bronchitis generally begins with the symptoms of a common cold, such as a runny nose, a sore throat, chills, general malaise, and perhaps a slight fever. The onset of a dry cough usually signals the beginning of acute bronchitis. The inner wall lining the main airways of the lungs become infected and inflamed. Inflammation increases the production of mucus, which then narrows the air passageways. If the condition persists for more than 3 months, it is then referred to as chronic bronchitis. The changing of the clear or white mucus to a yellow or green color usually indicates a bacterial infection. Most cases of acute bronchitis disappear within a few days without any adverse effects, although a cough can linger for several weeks. Antibiotics may be prescribed if the bronchitis is caused by a bacterial infection. Getting a yearly flu vaccination may reduce the risk of acute bronchitis resulting from influenza. Other preventative measures include good hygiene, including hand washing, to reduce the chance of transmission. Pneumonia can be caused by several different bacterial species. It can be either community-acquired or hospital-acquired. The term pneumonia refers to microbial disease of the bronchial tubes and lungs. A wide spectrum of organisms, including viruses, fungi, and bacterial species, may cause pneumonia. Pneumonia is characterized by an inflammation or buildup of fluid in the alveoli. In the United States, some 3 million people develop pneumonia each year. 17% of these people are hospitalized, and 5% die as a result. Typically, pneumonia refers to patients complaining of a cough, fever, and chest pain. Over 80% of bacterial causes of typical pneumonia are due to the bacterium S. pneumoniae. S. pneumoniae also causes pneumococcal pneumonia. Patients with pneumococcal pneumonia experience high fever, sharp chest pains, difficulty breathing, and a rust-colored sputum. When Streptococcus pneumoniae infects an entire lobe of the lung, it is called lobar pneumonia. If both left and right lungs are involved, it is called double pneumonia. When the pneumonia results in scattered patches of infection in the respiratory passageways, it is then referred to as bronchopneumonia. An adult vaccine immunizes against 23 serotypes that are responsible for almost 90% of pneumococcal pneumonia cases. Legionnaire's disease is caused by Legionella pneumophila. Cooling towers, industrial air conditioning, cooling water, industrial air conditioning cooling water, lakes, stagnant pools, and puddles of water have been identified as possible sources of this pathogen. After breathing contaminated aerosolized droplets into the respiratory tract, this disease develops within about a week. Human-to-human transmission of Legionnaire's disease does not occur. Legionnaire's disease usually causes severe atypical pneumonia, characterized by headache, fever, a dry cough, and some diarrhea and vomiting. In addition, chest x-rays show a characteristic pattern of lung involvement and necrotizing pneumonia, which is the most dangerous effect of the disease. Erythromycin is an effective treatment for most incidents of Legionnaire's disease. Thank you for watching.